Lola is a community organization, so it started by the community themselves organizing themselves so that they could start an hospital that could help their community members, because people were walking long distances before they could get services.
Globally, we have over 250 million children who fail to reach their age-appropriate milestones.
According to UNICEF, over 200 million children globally fail to reach their developmental potential in the first 5 years of life due to poverty, nutrition deficiencies, poor health, and psychosocial services.
Nurturing care opuonjowa ni mondo mi wariure e tich kanyakla mondo mi dongo mar nyathi obed makare.
We have nurturing care framework incorporated in the community health strategy, so it becomes easy to then incorporate this as a package that community health workers are delivering on top of what they have been delivering on a day-to-day basis. So last year there was the launch of the new community health strategy and also policy. So inside there is nurturing care as some of the services delivered at household level by community health workers. So that gives us a very, very good opportunity to then now scale up the work with community health workers in delivering nurturing care at the household level.
World Bank records that many countries invest more in children when they are older, yet research shows that the returns on investment are more substantial in children during their earlier years.
ECD has strengthened maternal and child health. The nurturing care components, there are 5. Okay, we have good health, we have adequate nutrition, we also have nurturing and care. 4th one is we have safety and security. And then finally we have opportunity for early learning, where we measure on play. Yeah, we always encourage them to let the children play, because play develops so many things in a child.
Through its community-led health model, Lola Community Alliance aims to build the capacity of rural communities to advance their own comprehensive well-being. It is within this model that Lola implements a robust ECD program based on WHO's Nurturing Care Framework.
The ECD program, when it started, I've gone training twice. We have the first one was the introduction into the ECD. Then we had another one on toy making.
In the last year, Lola incorporated nurturing care components and care for child development into its community health services to further improve health outcomes for young children.
I've been taught on the maternal and child health, the ECD one, the sexual reproductive health, and even the COVID-19 as a respondent CHW. And this one has also helped us, because whenever I have the knowledge, I disseminate to the community members. This one has helped a great deal, and our lives have improved.
Each month, community health workers conduct integrated parenting sessions where caregivers of children between the ages of 0 to 4 years receive parenting education to enhance their skills. Healthcare workers based in Luala and its partner facilities, on the other hand, engage ANC clients on early stimulation sessions on play and communication for caregivers.
In Migori County, we started 2016. That is when the national government trained the national trainers. I was one of them, trained as a national trainer in 2016. In 2017, we did another 2. So as a county, we have 3 trainers as national trainers for care for child development. We realized that number was not enough, but we continued introducing it because it is also incorporated in the government mother-child booklets. So through that, we've been having orientation of healthcare workers, but the real scale-up has come to us last year and last year, but one through the support of Luala Community Alliance, where they are really, especially, we are having now Rongo sub-county, which is one of the sub-counties, as a pilot sub-county, because in all the 11 GOK facilities, okay, the 9 plus 2 private, have healthcare workers trained. According to Case Foundation, ECD interventions should focus on both long-term and immediate changes in the lives of children. Luala's ECD program integrates immediate services like immunization, NHIF, and birth registration with caregiver education on the importance of early stimulation and responsive parenting. Children also get to play using toys created from locally available materials. These initiatives go a long way in preparing children for better outcomes in life.
Lola is a community organization, so it started by the community themselves organizing themselves so that they could start an hospital that could help their community members, because people were walking long distances before they could get services.
Globally, we have over 250 million children who fail to reach their age-appropriate milestones.
According to UNICEF, over 200 million children globally fail to reach their developmental potential in the first 5 years of life due to poverty, nutrition deficiencies, poor health and psychosocial services.
Nurturing care opuonjowa ni mondo mi wariure e tich kanyakla mondo mi dongo mar nyathi obed makare.
We have nurturing care framework incorporated in the community health strategy. So it becomes easy to then incorporate this as a package that community health workers are delivering on top of what they have been delivering on a day-to-day basis. So last year there was the launch of the new community health strategy and also policy. So inside there is nurturing care as some of the services delivered at household level by community health workers. So that gives us a very, very good opportunity to then now scale up the work with community health workers in delivering nurturing care at the household level.
World Bank records that many countries invest more in children when they are older, yet research shows that the returns on investment are more substantial in children during their earlier years.
ECD has strengthened maternal and child health. The nurturing care components, there are 5. Okay, we have good health. We have adequate nutrition. We also have nurturing and care. 4th one is we have safety and security. And then finally we have opportunity for early learning, where we measure on play. Yeah, we always encourage them to let the children play, because play develops so many things in a child.
Through its community-led health model, Lola Community Alliance aims to build the capacity of rural communities to advance their own comprehensive well-being. It is within this model that Lola implements a robust ECD program based on WHO's Nurturing Care Framework.
The ECD program, when it started, I've gone training twice. We have the first one was the introduction into the ECD. Then we had another one on toy making.
In the last year, Lola incorporated nurturing care components and care for child development into its community health services to further improve health outcomes for young children.
I've been taught on the maternal and child health, the ECD one, the sexual reproductive health, and even the COVID-19 as a respondent CHW. And this one has also helped us, because whenever I have the knowledge, I disseminate to the community members. This one has helped a great deal and our lives have improved.
Each month, community health workers conduct integrated parenting sessions where caregivers of children between the ages of 0 to 4 years receive parenting education to enhance their skills. Healthcare workers based in Luala and its partner facilities, on the other hand, engage ANC clients on early stimulation sessions on play and community.
As we are outside, Dr. Mo.
Lola is a community organization, so it started by the community themselves organizing themselves so that they could start an hospital that could help their community members, because people were walking long distances before they could get services.
Globally, we have over 250 million children who fail to reach their age-appropriate milestones.
According to UNICEF, over 200 million children globally fail to reach their developmental potential in the first 5 years of life due to poverty, nutrition deficiencies, poor health and psychosocial services.
Nurturing care opuonjowa ni mondo mi wariure e tich kanyakla mondo mi dongo mar nyathi obed makare.
We have nurturing care framework incorporated in the community health strategy. So it becomes easy to then incorporate this as a package that community health workers are delivering on top of what they have been delivering on a day-to-day basis. So last year there was the launch of the new community health strategy and also policy. So inside there is nurturing care as some of the services delivered at household level by community health workers. So that gives us a very, very good opportunity to then now scale up the work with community health workers in delivering nurturing care at the household level.
World Bank records that many countries invest more in children when they are older, yet research shows that the returns on investment are more substantial in children during their earlier years.
ECD has strengthened maternal and child health. The nurturing care components, there are 5. Okay, we have good health, we have adequate nutrition, we also have nurturing and care. 4th one is we have safety and security. And then finally we have opportunity for early learning, where we measure on play. Yeah, we always encourage them to let the children play, because play develops so many things in a child.
Through its community-led health model, Lola Community Alliance aims to build the capacity of rural communities to advance their own comprehensive well-being. It is within this model that Lola implements a robust ECD program based on WHO's Nurturing Care Framework.
The ECD program, when it started, I've gone training twice. We have the first one was the introduction into the ECD. Then we had another one on toy making.
In the last year, Lola incorporated nurturing care components and care for child development into its community health services to further improve health outcomes for young children.
I've been taught on the maternal and child health, the ECD one, the sexual reproductive health, and even the COVID-19 as a respondent CHW. And this one has also helped us, because whenever I have the knowledge, I disseminate to the community members. This one has helped a great deal, and our lives have improved.
Each month, community health workers conduct integrated parenting sessions where caregivers of children between the ages of 0 to 4 years receive parenting education to enhance their skills. Healthcare workers based in Luala and its partner facilities, on the other hand, engage ANC clients on early stimulation sessions on play and communication for caregivers.
For Migori County, we started 2016. That is when the national government trained the national trainers. I was one of them, trained as a national trainer in 2016. In 2017, we did another 2. So as a county, we have 3 trainers as national trainers for care for child development. We realized that number was not enough, but we continued introducing it because it is also incorporated in the government mother-child booklets. So through that, we've been having orientation of healthcare workers, but the real scale-up has come to us last year, but one through the support of Luala Community Alliance, where they are really, especially, we are having now Rongo sub-county, which is one of the sub-counties, as a pilot sub-county, because in all the 11 GOK facilities, the 9 plus 2 private, have healthcare workers trained.
According to Kay's Foundation, ECD interventions should focus on both long-term and immediate changes in the lives of children. Luala's ECD program integrates immediate services like immunization, NHIF, and birth registration with caregiver education and the importance of early stimulation and responsive parenting. Children also get to play using toys created from locally available materials. These initiatives go a long way in preparing children for better outcomes in life.
And Ruth is also not here, so I take note of that and I'll be guided. Madam Chair, I think we will skip that session and move on. So today's program, I'm drawing attention to the new program, hoping that this one will be projected. But as it is, it looks like
recording in progress.
It will take a little time before it is projected. So this morning, we are meant to have registration and exhibition, people walking by the exhibition booths So as you walk in, the initial few minutes we have given you to do that. We were meant to have started at 8:35, to be done by 8:35 with the registration and exhibitions. Now that has not happened. So, that has happened, sorry. So I want us to look at the recap of day one, which we'll skip for now because of the constraints on time and the personnel who are supposed to do it not being around yet. At this hour, we want to get into the session where we will have guest speakers, and each one of the guest speakers has an area that they'll be tackling. So this is the order in which the guest speakers are going to make their presentations. We have Dr. Elizabeth Omondi, who is already here with us, and we appreciate that she was here very early. She is a member of the Smart Start Siaya executive, so she'll be coming on to give us her talk on teen motherhood and the plight of teen mothers based on practical experience. She'll be followed by another guest speaker, and this is Dr. Caroline Monge. Dr. Caroline Monge will be joining us virtually, I assume, and therefore I would like that is Elsa here and the health team, the team from the Ministry of Health, yes. So please just make sure that we have Dr. Carol ready, or she's on her way. Okay, we will assume her way is here. So, all right. So, in case Dr. Carol is not able to get here in good time, we will have the Deputy Commissioner, the Kenya Prison Service, present to us, and therefore we will have her ready, and her presentation, I think, is ready, and she's here. We appreciate that, Madam Deputy Commissioner, you are ready for that. And then we will have the team from Save the Children, and Irene Wali will be making a presentation on the use of IDELA for ECD learners assessment. Very important. After her, we will have a conversation on community health volunteers and the strategies that they adopted to help children thrive in the midst of COVID-19. That will be from Path. And then we have an endline survey on Let's Play, Spaces for Kids to be Kids, a project that was implemented by UNICEF in Samburu and Isiolo. And we have Fariza Baidali, who will be making that presentation, and Fariza will join us online. And then finally, we will have Professor Amina Abubakar, the director of the Institute for Human Development at Aga Khan University, who will be making a presentation on childcare for vulnerable groups. And that will cap for us that session. Then we have our tea break. After our tea break, we will go into concurrent sessions. Are we together? Munafuata program tafadhali. All right, yes. So we are going through the program. The concurrent sessions, once again, I implore you to look at the abstracts and determine where you would want to go if you have yet to do so. So there is breakout room number 1, where we have the chair as Dr. Anil Hamis. And this will be one that will be focusing on rethinking childcare, workforce, and SDGs together with emerging issues. So Dr. Anil Hamis will be chairing that first one in breakout room number 1, and breakout room number 1 is this one. This is our breakout room number 1. So rethinking childcare, workforce, the SDGs, and emerging issues. And then we have the second breakout room, and that second breakout room is one that will be chaired by Dr. Benson Odongo from Jaramogi Oginga Odinga University, and it will be on the implication for practice and policy, community responsibility and responsive child caregiving. So a couple of topics lumped together. That is what will be happening in breakout room number 2, which is where we were yesterday for those of you who are present. So we will be heading in that direction. And we have Mumbi Mugwongo, who will be directing most of us to those rooms. She'll be in the room shortly. She's attending to a matter and then she'll come in. And then the third one is breakout room number 3. And this will be chaired by Immaculate Salaon. Immaculate is from Community Initiatives. And she will be chairing a session that will be on the Afghan catalog of abstracts for the ECD Net conference. A variety of topics. One on the quality of early childhood care in informal and home-based daycare centers in Dagoretti. The other will be the status of pre-primary education policy implementation. The other will be using community activators as grassroots advocates. And the last one will be the Kenya County ECD profiles. And so this will be a very useful session that will again be led by Immaculate Salaon. After we are done with that, which will be at about 12:30, it is anticipated that we will come back here for, we will actually come back here, not 12:30, sorry, at 11, not 12:30, at 11. We will come back for a plenary in this room. All of us will come from our rooms and come in for a plenary. Then the county governments will be sharing on progress made in ECD. So they'll be given an opportunity to do that in here. And once they are done with the sharing, we will break for lunch and come back from lunch and go into the second breakout session for the day. And this will be one that will run from 1:45 or 1:35 or thereabouts to 2:40 p.m. And this will be on using technology to improve literacy in the global south. That will be a session that will have Emmanuel Coril, Rosie Minza, and Professor Alexandro Gotardo from the World Vision of Kenya sharing that session, sharing the experience during that session. And this will happen in this room. So all of us will be present. And then after that, we will now have the breakout sessions for the yesterday's program that was carried forward. And that will be from 2:40 to 3:25. The concurrent sessions will be on number 1, policies, guidelines, regulations, and financing in childcare settings. And this will be a session that will be led by Leonard Chumo. And then we will have the second breakout session. Leonard's session will be in this room. Breakout session number 1 will be here. Breakout session number 2 will be in the lecture rooms that we had yesterday. It will be chaired by Carolinda Award from Luala. And it will be on childcare and women's economic empowerment and male involvement in childcare work. And then we will have the third breakout room session. And this will be chaired by Linda Haremwa of UNICEF, and it will be on childcare in humanitarian settings. And we will close our day at about 3:25, 3:30 p.m. today. That's our anticipation. We adopt the program. Do we adopt the program? Asante. So we are now ready to kick off. Dr. Elizabeth, like I said, is already here. So we are going to have our guest speakers take us through the first session for the day. If we could be comfortably seated and take notes, and then we will have our plenary session following later. I would want us to begin now. So asante sana, and I noticed the arrival of the head of the division for neonatal and child health, Dr. Carol Monge. Karibu sana, Daktari. We appreciate your presence. Asante, traveling from Nairobi to be here is a big thing for us. We appreciate you. Just 1 minute. Sawa sawa. So, like I said, we are beginning with Dr. Elizabeth Omondi, and then we will have the commissioner, and then Dr. Carol will come after the commissioner because the commissioner has to travel. So we are appreciative of your indulgence, Carol, on that, Dr. Asante. So, all right, so Dr. Elizabeth, Bika, B. Hebu tumkaribishe Dr. Elizabeth. Sikupewa profile, lakini huyu ni guru. Sasa sijui ni nani ataniambia kuhusu Dr. Elizabeth. We've been told to use the sign language.
Good morning. Okay. Good morning. God is good and all the time. Okay, I'm going to present on teenage motherhood and the plight of teen moms. I'm called Elizabeth Omondi. I'm a lecturer at Jaramogi Oginga Odinga University of Science and Technology. This university where you are, though currently I'm coordinating a program with USAID, which is a grant that Jaramogi received. And I'm also one of the founder members of Smart Start Siaya and a technical lead in that program. So the plight of teenage mothers, and I want to start by saying that I'm sharing this from experience and for having been a coordinator for adolescent health in this country for more than 10 years. My question is, what are we doing? Today we are seated here to discuss interventions, studies, and even share those lessons that we've learned through implementation of activities in support to mitigate teenage pregnancy. But the question is, are we achieving anything in what we are doing? I was happy to hear that there are so many presentations on adolescent pregnancy, success stories about interventions that are geared towards mitigating teenage pregnancies, success stories about interventions that are supporting the children of the children born from teen mothers. But my question is, are we leading anywhere? So as we sit here today, I think my presentation is just to give insight on what is happening and how we must re-strategize if we have to curb the menace. So statistically, globally, it is acknowledged that there is high rise in teenage pregnancy. And as we sit here today, we agree that teenage pregnancy is on the rise. Last year, we blamed COVID for the high rise of teenage pregnancy. I don't know what we will blame the coming years, because if I share for you the data for this country on teenage pregnancy, then you'll be surprised that the situation has remained the same for the last 5 years. With or without COVID, the situation has remained the same. With all the interventions that have been presented here, were presented here yesterday, will be presented here today, even tomorrow, the statistics remain the same. So are we all moving towards a direction that is going to help us to reduce teenage pregnancy? That is still my question. In the year 2016, 2017, that financial year, children below 14 years who are pregnant were 24,666, about 25,000. The following year, 2017, 2018, that is in Kenya, and this is data extracted this morning from Kenya Health Information Software. So the following year, it was 24,000, a difference of just about 1,000. The following year, 2018-2019, it was about 21,000. Then for the year 2019-2020, which is the peak, was the peak of COVID, it was 15,000, a drop of 5,000. But we blamed the high rise of teenage pregnancy on COVID. This year, that is 2020 July to now, it is again 25,000. We have managed to control COVID. The children are in school. The teenage pregnancies are still on the rise. That is a child below 14 years, 10 to 14 years. And the data we are presenting here is only for children who have come to a health facility because they are pregnant. How many did not come and were pregnant at home? And we don't know the results at the end of the 9 months. Now, for the children who are now, the teenagers, 15 to 19, it is worse. The 2016-2017, 311,000 were pregnant. 2017-2018, almost 400,000 were pregnant, no COVID. 2018-2019, almost 400,000 were pregnant, no COVID. Now with COVID, that the year 2019-2020, there were only 330,000 who are pregnant. We still blame to date teenage pregnancy on the COVID pandemic. Are we being sincere with what we are saying? This is data from KHIS extracted this morning. So at the end of the day, the percentage, the coverage has been 29% 2016, 29% 2017, 29% 2018, 24% 2020, and 2021, 21%. And you can see the year of COVID, it was even lower. We have interventions. We are getting funding to support reduced teenage pregnancy. We are presenting best practices. We are presenting lessons learned. Are we sincere in the reduction of teenage pregnancy? Now, I want to say this. We all know what teenagers go through, especially when they get pregnant. And why is it that we've not thought of what happens before they get pregnant? And the question is, when we talk about nurturing care for early childhood development today, we may think it is only going to help the child to transit to preschool smoothly. But the question is, do we understand the stages of development as the team that is seated here today, so that we galvanize resources towards support for what is going to give us results? Why am I saying this? I'm saying this because as a parent who is seated here today, as a mother, as a father, as a brother, we engage with adolescents. Have we played our role? Or do we wait to receive funding to support a group where we are working, when in the neighborhood we have not done anything? Do we have adolescents? Do we have teenagers in the neighborhood? That is my question. Are you able to attribute any success of a particular individual because you supported that individual as a person? Because it starts with us, and we must bring a change for this to stop. I'm saying this again because today, if you talk to adolescents, and I talk to adolescents a lot, when they move from childhood to adolescence, it is a period that all of us went through, and it is a period of total confusion. According to a psychologist by the name Erik Erikson, that is the 5th stage of development. And it's a stage that if you do not help an individual to negotiate, then that is the trouble. That is the teenage pregnancy. Because what happens, there is identity versus identity confusion. It is the caregiver, the parent, who brings all these confusions. It is you and me. A young girl who has been your baby in the house, the breast starts growing. And the next thing you tell her, I can see you are really walking with your chest ahead. Unataka watu waone nini? What have you started doing to this teenager? The next thing in the Luo community, you will be told the moment your breast starts growing, they know you started going for your menstrual periods. And therefore, you cannot stay in the same house with your father. And especially if your mother is still within the reproductive age. So then what are you told? Now you have to move from the household where you've been sleeping to go and share some houses elsewhere, or to go and sleep in the kitchen. Under normal circumstances, which animals sleep in the kitchen? Which animals sleep in the kitchen? Yes? The chicken, isn't it? Or the goats. So the adolescent, transiting from childhood to adolescent, takes you to be in that category, where you're going to sleep with the chicken, you're going to sleep with the goats. If the worst comes to the worst, you are going to borrow sleep. In Luo communities, borrowing sleep in the neighborhood. What is it that we are doing to this adolescent, or what is it that we are communicating to this adolescent? And you as the neighbor, what have you done? You're already telling her that now you don't belong in this household. You need to exit and get another place. And there, outside there are opportunists who are seeing this girl struggling to move from the house at 9 p.m. to go to the next neighborhood. And the opportunists will provide comfort to this girl. And this is the man you will talk about, a boda, you will talk about somebody, a cow, somebody who is taking care of her somewhere, or any other boy who takes advantage of this girl. So at the end of the day, what happens, it is because of the caregiver, it is because of the parent that is pushing this girl out of the household to go and get pregnant. Because at that point in time that you are being told that now you cannot sleep in your bed that is comfortable, then you are being told to look for a comfortable bed somewhere, and that is what brings this problem. Now, what is it that we are doing? We are looking for support. We are engaging adolescents because they are pregnant to discuss issues of how we can support them to go back to school. But what I want to say today, we must address the problem up the stream, not down the stream. We have been addressing the problems down the streams with all those presentations we've made here, but I can tell you for free that there has been no success. Even if there has been success in your small organization, it does not represent the country's success. And that small success you have got cannot help us. We want a situation where we can help all our children to transit from childhood to adolescent and to adulthood without a problem. And the solution is addressing the problem up the stream. And which up the stream am I talking about here? No, where it all begins. Nurturing care for early childhood development is the solution here. We have to nurture values, we have to nurture spirituality, and we have to nurture care. Care for the child 0 to 3, we continue inculcating good values, and we nurture their spirituality. That is the only magic bullet. These others that we are talking about, probably we have become opportunists who are asking for money in human-centered design. There are some models that are being presented. Those models are not helping our adolescents because you are already addressing the problem down the stream. She has given birth, she has a baby. We even forget that with that situation, she could even be having fistulae, and most of them are actually suffering because they have got hidden problems that they do not understand, and we do not go in depth to find out what these problems are. We have to address the problems up the stream. My plea is that as we think about wanting to help the adolescent, we must start at age 8. It is nurturing care, taking care of the baby and transiting to school, but can we nurture values the way other countries have done it successfully? So that as the girl is growing, she understands herself and knows that if I do do's and these are the don'ts, that is what will give us a breakthrough with regard to issues of teenage pregnancy. The second one, starting small, thinking big. You are a responsible person in this room today. What is it that you can do yourself with your resources without asking somebody to help you? In your neighborhood, there are young girls. In your neighborhood, there are children. What is it that you can do to this young girl, to this young boy, to make a difference. The last one I want to talk about, inculcating good morals. And this we have to do by seeing how, again, we can preserve the traditional cultural norms that were helping us, that helped some of us to reach where we are today. What is it that we can do to motivate a girl child to remain a virgin? That when she's getting married, there is a reward that she's a virgin. In the Luo community, that used to happen. And if you are married as a virgin, you would get a lot, your parents would ask for a lot of dowry compared to that girl who is going in with a child. In the Luo community, there were those penalties that would be given to any man who is found to have impregnated a young girl. Today we have the constitution, we have the penalties for such victims. But if you go to Siaya court today, the numbers that are pregnant that I've talked about, over 300, the victims that are taken to court, it's almost 1%. Are we saying that we cannot interrogate the girls to identify these perpetrators so that we victimize them, and that becomes a lesson? And I like what Mutula Kilonzo said, that if we are now embracing moral decadence, then it will continue. Because all of us feel that it is not my business to take care of the neighbor's child. But if you look at the act, the Children's Act, you look at all the policies that are there, it is your responsibility as a neighbor, it is your responsibility as a community person to collectively join with the parents to ensure that this girl's life is not ruined because of pregnancy. Nurturing care values and spirituality. If we all unite towards ensuring that our children are well nurtured, we inculcate good values, we inculcate spirituality throughout the time the child is growing, then we'll get a breakthrough. Rather than waiting to mobilize at a time when this girl has gotten pregnant or is given birth and we want to support. I think that issue of addressing the problem downstream, we may have to see how to change it so that we address the problem at a point that a girl grows up knowing herself and she's able to protect. Because a reward, you will be married and you're a virgin, something. And there's a celebration of that effect that will show everybody. Because if it's hidden, don't know that. Then our children do not have anything to inspire them. Thank you.
Thank you. Thank you. Thank you so much. Thank you so much, Dr. Omondi. Thank you so much, Dr. Omondi, for that insightful conversation. You've welcomed us. Thank you so much, Dr. Omondi.
We get some sound. Please.
Apologies. Thank you so much, Dr. Omondi, for that, welcoming us to have that insightful conversation, reflecting on the teenage girls and just how we can support them, even as we focus on the well-being as children, as they bear their readiness to being mothers, and supporting them into that process. Because as we say, the life of a child is important from before conception. So the health of a teenage mother is important. And thank you for inviting us to reflect on that. We want to move ahead with the day. Allow me to welcome Madam Florence Monge from Commissioner Prison Service, to also take us through a journey of just reflecting on what it means for the prison service and the child in those spaces. Remember, the theme is focused on looking at children in those diverse circumstances. And so this is a unique space. I want to invite us. I think those of us who are in yesterday, I think had some reflections and just insights. I think let's allow her to share with us more of that today after giving us just a tip yesterday. Thank you and welcome.
Thank you very much. Thank you very much, Joy. Our Director, ECD Network Kenya, all the distinguished participants, ladies and gentlemen, God is good and all the time. Thank you very much. It's another beautiful morning that we are here to discuss matters children. These are matters very close to our hearts, our chests, and I know that that is why we are still here. And the room is full, by the way, and it's exciting to stand here because you see everybody and you see the eagerness with which we want to share the experiences. Dorothy. I am not breaking protocol. Where we come from, they say that when I stand here, somebody should be behind here just in case he decides that he's standing against me, and that Madam Teresa will be held fairly responsible. So thank you very much. My name is Florence Omondi Momanyi. I'm the Deputy Commissioner General of Prisons, like has already been said. And I want to bring very warm greetings for our Commissioner General of Prisons, Mr. Wycliffe Ogalo, who has said that before I say anything, I should say that I'm here legally. And I should also say that I don't know how that a child is embedded on the back of each one of us. So he said I should start by saying that. And he's very passionate about matters children. That is why you've seen in the Kenya Prison Service in the past, like 1 year, there's a lot of emphasis on children accompanying their mothers in prison and children generally. We have different categories of children, just to give you a brief background in prisons. We have 4 institutions for children. One is the Boston Institution for Girls. These are girls aged between 15 and 17 years, the ones that Tari was talking about. They are in Kamai Girls Boston Institutions in Nairobi. We also have, because they've committed some offense, and you have said they should come to us. Then we have boys the same age in Shikusa in Western Kenya, and in Shimolatewa in Mombasa. Then we also have what we call a Youth Corrective Training Center, and we only have one in the country, in Kamiti. It holds boys between the ages of 17 and 21 years who have also committed an offense. These boys are only with us for 4 months to go through what they call a short, sharp shock. The 5th category is what makes me to be here today, and these are children accompanying their mothers in prisons. These are children who are sometimes not seen by the judicial system. Why? Because they could be in the womb by the time the mother comes to us. So the children gets introduced along the way or when they are already with us, meaning then that it is possible that they are not even budgeted for, meaning then that it is possible that nobody really thinks about them because you don't see them. Because the mother works with this baby, the mother gets convicted and gets convicted with this baby. And therefore, these are very, very unique group that we are talking about. We have, that this morning, 51,100. And so inmates, we have about 3,000 female offenders, and we have 250 children accompanying their mothers. The population of children is normally high, but with the COVID-19, the population of children came down because they argued for their alternative sentences for the mothers. The mothers got released and the children also went back home. And therefore, that's some intervention that we may discuss at another level. The Kenya Prison Service, for those who are not aware, is in the Ministry of Interior, the coordination of national government. We contribute to public safety and security, and by ensuring that all persons who are legally committed to the prison facilities in the country have safe custody. And by so doing, you are safe to contract your businesses. So when we keep the 50,000 people, you are safe to sit here. If we open our prisons, you may not sit here. And therefore, we have an important mandate in this country. We ensure that we contain these prisoners and rehabilitate them at the same time. We also ensure that we facilitate administration of justice. That simply means taking those inmates to court every morning. Fourth, we train youthful offenders and prepare them for entry into society. Sometimes a girl conceals birth, or you call it abortion, whatever it is. To the judicial system or to the legal system in this country, that is an offense. Dr. Omondi will say no. And then as you bring this, sometimes the girl has also attempted, but finally they'll still give birth when they're with us. And finally, we provide for the care of children aged 4 years and below, accompanying their mothers in prison. This is the team that I'm going to talk about. As I mentioned yesterday, we have 43 penal facilities in the country, and therefore the 250 children are spread across those penal facilities. And when they are with us, until now, when the ECDE came on board and did a lot of sensitization, and until the African Early Child Network collaborated with us and other agencies in there wasn't a sharp focus on these children. We only got to well-wishers and partners for a few basic necessities, and we said we were taking care of those children. Actually, since I knew that a child's 1,000 days are critical, it is not even 1 year. It is about a few months, 3-4 months. Therefore, we've now started realizing that the baby in the womb is a person. They should be taken care of from that point, 0 to 4 years. Otherwise, if we lose them at that point, then we'll be getting where the speakers have spoken about, and Dr. Omondi has already said that we are doing nothing. I'm standing here to say we are doing something, and that is why we are here. If we were doing nothing, then I think we couldn't be here saying 0 to 4. And for me, 0 to 4 is important because this child comes to us without a warrant. It is now when we've started doing a P&C form, that is a protection and care form for those children accompanying their mothers, so that as the mother goes to court, this small form is also alongside the mother's form, so that then the judge will know that this woman has a baby. And much as we've been doing so much, if that focus was not given, then it means that this child gets lost in that system. Currently, the children basically stay with their mothers in prison. They go through the same routines that the mothers go through in the prison. And this then means that the child basically is a prisoner. And what we do is that we provide care, antenatal, postnatal, for the mothers, for the children. We are now in the process of establishing safe spaces for the children. We ensure that there's registration of these children, and the registration should not indicate that the baby was born in prison. Just the same way your baby, the birth certificate of your baby does not indicate that they were born in the village near a river. And then we provide for the preparation into the early preschool, so to say. We give a balanced diet. We provide the basic necessities like the clothes, the beddings, and the play items. And now in collaboration with the Afghan NCAJ, the Clean Start, and other partners like Faraja and others, we are now in the process of doing a policy for the children. Thank you very much, Afghan ECD Kenya. We can't thank you enough. Thank you so much, because now we are now getting into a system where we can be provided for in terms of budgetary allocation, and the children will now have their space. They will not be there as an accident, but they'll be there because they belong there as at that time, because you cannot separate the baby in the womb from the mother. Therefore, it means that until this mother leaves the prison, the baby will be with us. And during COVID-19, what we did is that we were able to reduce the numbers, like I've already mentioned, thanks to the judiciary. We were able to collaborate very well with the NODC, ICRC, Kenya Red Cross, Legal Resources Foundation, Justice Defenders, and others to donate like talk time, phones and airtime, so that the mothers would be able to communicate with the other siblings left at home and the other family members. We were able to train human rights officers to be able to be sensitive and to address matters affecting these children. We made use of the virtual courts, and therefore we want to say thank you very much to all our stakeholders. And then this gives also others an opportunity for collaboration and partnership. We have several challenges, like insufficient suitable facilities, such as separate mother and child units. We have limited awareness on child development and basic training on healthcare of children among staff. Capacity building is a challenge. Visitation of these children is a challenge. Therefore, they are not connected to their other siblings, and they suffer a lot of trauma, and we do not have a system yet of addressing the psychosocial needs of these small children, because you know we are paramilitary. We are uniform disciplined officers. Therefore, this child gets lost in there, but a lot is happening so that then these are addressed. I've already mentioned opportunities for collaboration. You can pick them. And I want to appeal to all of us to work with the Kenya Prison Service so that we can address the plight of children accompanying their mothers in prison. And there are a lot of opportunities for all of us. I want to tell you one thing, that you can find yourself in prison anytime. And when you get there, you get disconnected from your children. And if you are a woman and childbearing, you might get there and you are carrying this baby. You have been raped. You may have killed the father of this baby because of issues or matters beyond your control. And you can imagine what this child goes through as you serve that sentence. Therefore, let us be sensitive. Let us appreciate the people who take care of these inmates. Let us also join hands to improve the infrastructure, because you never know when you can get there. Let us open the doors of classrooms, and that will close the doors of the prisons. Prison is not for children. Prison is not even for any of us. Prison is not that space that you could call a safe space for children. However, because there's a child embedded on the back of each parent, like my Commissioner General keeps reminding me, and we are at the tail end of the justice system, you might find yourself there somehow, and your baby might find themselves there somehow. And should that happen, let us collaborate, let us partner, let us ensure that the systems, legal, political, social, economical, educational, all of them are good enough for these children. The children of prisoners are the invisible victims of crime and the penal system. They have done no wrong, yet they suffer the stigma of criminality. Their rights to nurture are affected both by the criminal action of their parents and the state's response to it in the name of justice. That is an quote from an anonymous person. Those are children. They get to the system, they go to school. We have some of those facilities, like you can see. Yes, Guinea. They're just normal children. Yes, you can see that is a very interesting picture. Can you imagine that is a soldier? That's a soldier in uniform. These children get militarized. They will squat, they will head count. You know, as head count means 1, 2, you know, head count, as in head count. Yeah, we don't fill our form, we count. So these children know head count, they know how to march, they know Afande and Madam. That is a child who is already military. I want to appeal to all of us to come up with systems that will help address challenge, the damage that we have done. I am only doing my part by keeping the mother. The mother holds the baby. The link between the community and us, the mother. So this child belongs to us because we hold the mother whom you have. Thank you very much, and may God bless you.
Thank you. Thank you.
This lady here is called Dorothy Ngugi. Dorothy Ngugi works with the children. She's here because she's being fed so that she can step in this.
Good morning, all of you. My name is Dorothy, as you heard Madam say, and I would like to follow her footsteps. She's done a lot for the children within the prison. What I would urge you all, the partners, the government institutions that are represented here, come in for the children that are in prisons, and especially in institutions, flanched areas. Those need total support. We concentrate so much in institutions that are in towns like Nairobi, Kisumu, but the far-flanched institutions like Lodwar, Kapenguria, we don't have much partners. So if you have time, if you have a talent, and especially the ECD teachers who are here, find time, step into our prisons during your free time, talk to these children, and provide any service that you think is beneficial to the children. We will appreciate so much. Thank you so much.
Thank you. Thank you, Madam Commissioner and Madam Dorothy. I think that for me makes us have the essence of why we have this conference. We've brought to the table one of the faces that are most forgotten. And I think it's just a call to remind us that it's a space we need to think about. We want to loud the process of the policy making so that these children can as well be shielded, be protected, and be given an opportunity to not just survive, but thrive to the most highest potential. And I think that's why we're here. Because of time, I will quickly want to welcome our next speaker. The next speaker is Dr. Caroline Monge, Head of Department of Neonatal and Child Health, Head Division of Neonatal and Child Health, Department of Family Health, Ministry of Health. You know we are here because Ministry of Health is a critical partner. So let's hear from the ministry. Karibu sana daktari.
Good morning. All protocols observed. Thank you for this opportunity to join you in the 4th National ECD Stakeholders Conference. So I head the Division of Neonatal and Child Health, and I was tasked to present on pediatric care amongst COVID-19 pandemic. So the outline of my presentation, I'll briefly take you through our mandate, our vision, our mission, our 4 indicators that we track. Then we'll discuss briefly about the COVID-19 pandemic and its effects on children, and look at performance trends of key tract indicators during this period and lessons learned. So our vision at the Division of Neonatal and Child Health is a Kenya where all newborns and children survive, thrive, and live to achieve their full potential. We also have a vision that to ensure survival, the health, development, and well-being of all newborns and children in Kenya through promotion of evidence-based interventions, which are high impact. More often, they're also low cost. And also to create an enabling environment for effective delivery of quality health services at all levels of service delivery. Now, our core mandate: to reduce newborn and child mortality and morbidity due to preventable communicable diseases. Communicable are the infectious diseases, and our top killers in Kenya are diarrhea and pneumonia, the under 5, and also significant contribution by neonatal mortality in the first month of life. We also have a mandate to reduce this morbidity and mortality due to non-communicable diseases and conditions, which mostly affect children between the age of 5 to 10. And also to promote access to quality and comprehensive early childhood development interventions for all children, especially in the first 1,000 days of life. And this is where we implement the nurturing care framework. Also mandated to promote interventions to end all forms of malnutrition and address nutritional needs amongst newborns and children. And overall, to create an enabling environment for us to be able to deliver these quality newborn and child health services. So a brief look at the numbers where we were. This is from the Kenya Demographic and Health Survey of 2014. We plan to conduct one next year, so we'll see how we've performed. So we can see over time from when we've been tracking these indicators, from 1978, 2014, we've seen a general improvement in the survival of our under 5s, our infants, and our neonates. The neonatal, when I say a neonate, I'm referring to a baby who's less than 1 month old, an infant, the child less than 1 year, and then there's the under 5 child. So current estimates from this year have us at 21 deaths per 1,000 live births for the neonatal mortality. For the infant mortality at 32 deaths per 1,000 live births, and at 43 for the under 5. It's important that I note that majority of deaths in under 5 children, up to 46%, occur in the first month of life. That is where we focus our priorities and our interventions. So then came COVID, first case in March of 2020. So as with all other sectors, there was, and especially the Ministry of Health, there was a refocus of priorities of activities. We were all tasked, we were all task shifted to support the country's efforts towards fighting the COVID-19 pandemic. So at both ministry and at partner level, we had reprioritization of activities, which meant that resources were also reallocated. and also meant that the partner support that we were receiving for some of our interventions for neonatal and child health were directed towards fighting the pandemic. And indeed, this was the same across many sectors and for both state and non-state actors. So this had a ripple effect on our programming, and we caused the negative impact on child survival and development. So there's something called the hidden impact of COVID-19 on child well-being. We were following the numbers. We saw that the children who were infected or indeed succumbed because of COVID-19 were not as significant as adults. However, there is the hidden impact. And this came from an analysis by Save the Children in 2020, which says the impact that we are not able to see at face value. So what happened, the first thing was there was closure of non-essential health services and hesitancy to access healthcare. You remember people were staying away from hospitals. Hospitals were also closing down the so-called outpatient clinics because they are non-essential, and they were only attending to emergencies. Hence, the ministry then came up with, immediately realized that there was going to be an adverse effect on our indicators. So there was a guideline that was released about continuity of essential and non-essential health services during COVID-19 with guidelines. We know there's also disruption in school attendance. For about 7 months, children were at home. They were not accessing education. We know for some counties, for some regions, these schools are the source of these child's, where they can play, where they can interact with other children, where they can even access a meal. So this disruption had an effect on the child. There was also limited access to the justice system before they reorganized because of closure of the courts and hence delays in some of the judicial processes. And parents and caregivers were also affected economically. So this threatened food security, so people migrating, and we all know the important role of a caregiver. If a caregiver to a child is not emotionally, mentally, if they're not in the right space, this can affect the care that they give to their child. There's also some data that we're able to access from our health information system about the impact on violence against children. So I picked 3 years, same period in time, to compare the number of cases that were being, these are the total sexual gender-based violence cases presenting in health facilities. So if we look at the age group 0 to 9 years, there's a change. January to July 2018, there were 985 cases. Then January to July 2020, there were a slight increase of 1,071. But we see that majority of children between the age of 10 to 17 years, there was almost a doubling of cases from January to July 2018 to July, and comparison the same period in 2020. And these are cases that present to health facilities, and we do know a significant number of cases go unreported. So our response, we developed guidance on service delivery. Now innovations came up and we all went digital, virtual. We held trainings and also sensitization meetings through the digital platforms. We did participate as a division in our national COVID-19 guidelines for children. We managed to conduct an assessment to monitor neonatal and child health service delivery. and also at the same time strengthen data reporting at both county and national level, and collaborated with other sectors to give the children a voice. So I'll quickly take you through our key tract indicators. Like immediately we noticed a drop in outpatient attendance for under 5 years. This is the time when there was hesitancy to access health facilities because of the COVID pandemic. But also we remember in the last months of 2020, there was an industrial action that affected service delivery. Quickly looking at children presenting with symptoms of pneumonia. Next slide. Please move the slide. Next. Next. Yes, I've explained about the outpatient attendance. The next slide, please. Yes, so the red line that we can significantly see is the year 2020. We had a reduction in the number of children presenting with symptoms of pneumonia. Slide. Also, under 5, diarrhea trends. Children who are pre-treated presenting with symptoms of diarrhea also significantly reduced. We could attribute this to improved eye infection prevention control measures such as hand washing and improved IC practices during COVID. Next slide, please. However, neonatal deaths have not changed. So we actually have to do we're doing a process of doing a deep dive because we are seeing our facility reported neonatal deaths were not affected. So what is it more that we can do maybe at community level to intervene? Next slide, please. So the next 2 slides are just a snapshot of our reported under 5 COVID-19 cases. So this may have changed. It's now about 2,000 cases. The mortality is still at less than 30 children. Next slide. So that's under 5. And then the next slide is under 10 years. So we did not have a large number of children being or suffering from COVID complications, as the adults have been affected, and most were traced due to household contacts. Next slide. So I'll wind up in the next 1 minute about the lessons learned. So we have learned that we have to be intentional in our programming for children in emergency settings, especially as the Ministry of Health, because these children are unique and their needs are unique. We also learned the importance of data to use in decision making and to strengthen this data collection at both facility and county level, and interrogation of this data and using it for multi-sectoral collaboration. Then the importance of flexible systems and structures to respond to emerging health issues, such as this pandemic with innovation. Teamwork cannot be emphasized. We all need to come together for ensuring our neonates and children survive. And the fact that a strike happened within a pandemic, we need to be prepared for this eventuality. It shows that anything can happen. And also the importance of policy and guidelines as a division. And this needs to take into account the environment at which we are in operation. And community health is a game changer. We are delivering services even for our newborns and children through the community health volunteers. So we need to strengthen our community health strategy programs. So I'll say thank you and end there. Thank you.
Thank you. Thank you, Thank you so much, Dr. I think just reflecting on COVID-19 and what it's brought, especially for children, and just thinking deliberately within that space. I think all of us have been operating within that space in our programming, and it is a good space to reflect and just see. Thank you for sharing the data. The numbers speak, they always say, and the evidence-based programming is the best way to go. After that insightful, I want to pick one last statement you just said. I think you ushered us literally into the next speaker, and you said strengthening community health strategy, CHVs. Our next speaker is from Perth, Beatriz Soyugi, and she will be sharing and reflecting the place of CHVs in supporting children, and especially, again, contextualizing it within this space. So welcome so much, Beatriz, on behalf of Perth. Karibu. And kindly, we are urging us to keep it 7 minutes because we have quite a tight program and a day to catch up with. As well, a session was missed yesterday and we're working hard to recover it. So apologies for seeming a bit tough, but we want everyone heard and appreciated. Thank you.
Thank you so much. Yeah, so my name is Beatriz Soyugi. I work for Perth in the ECD project. I'm a regional technical advisor for ECD. Happy to stand here, especially after Dr. Monge, having laid a very solid foundation about COVID and children in this country. So clearly, from her presentation, we know that COVID pandemic has had serious negative effects, a major impact on the capacity of the health system to continue with the delivery of essential health services. Since the onset of COVID-19 pandemic, the health system has had to balance out the need to prevent the spread of COVID-19, the need to care for COVID-19 patients, and at the same time, maintaining the delivery of essential health services. That has not been easy, especially to a health system that is already overstretched. For children, this foundation has had serious effects. And for some children, these effects will be lifelong, especially for children who are already at risk of poor development because of exposure to adversities of all sorts. So for them, the impact of COVID-19 would even be more serious. COVID-19, as presented by Dr. posed a threat to access to basic healthcare. Many children had to miss their vaccines. Many children could not access treatment at the right time. COVID-19, again, posed serious risks to child safety. Children had to stay in constrained environments, limited opportunities to go out and interact with other children. And within those environments, they had the risk of witnessing suffering from violence or domestic violence that we saw reported across the country. But look at it again. This period has also given us opportunities to better interact with our children. How? Because from such a long period, caregivers had to stay at home and work from home. That posed a very great opportunity for us to focus our attention on caring for our children. For the first time, many children had the opportunity to stay with their both parents at the same time. Many times, children are either with their mothers because fathers are outside working, or with their fathers, or with the childminders for a prolonged period of time. But for this reason, because we had to stay at home, children had the opportunity to stay with us. And so as caregivers, we have had the opportunity to communicate, to interact better with our children. The fact that families were staying together, people were not moving around, travel was limited, people were not going to work. That was an opportunity for safety and security for our children, and an opportunity for emotional connection with the parents and caregivers. But again, on the contrary, this period has posed serious challenges, as I mentioned already. So lack of physical space to play and interact with the environment for children, of course, that has had serious effects. Social interaction, so the lack of socialization with peers and going out to play. And of course, the challenges around exposure to poverty. Many caregivers lost their sources of livelihood. And as a result, many more children were exposed to lack of basic needs, things that they were used to getting, they were not able to access because of limited resources in the households. And most importantly, many children, as a result of intolerance between couples and in family settings, many children have been exposed to toxic stress during this time. And we can't underestimate the effect of toxic stress, the brain development of our young children. So now, as part, we have been working in Siaya County, supporting CHVs to integrate nurturing care messages and services into their routine household visits. We have trained them, they have the knowledge, they have the skills, and so as they visit households, they counsel caregivers on responsive caregiving, opportunities for early learning, safety and security, alongside what they routinely do around nutrition and health. We have also capacity built them to facilitate play sessions in health facility waiting areas. This they have done with a lot of ease, seamlessly integrating them in their routine work. With COVID, this had to change. Usually, as they visit households, what they're looking at is the quality interaction, the time they spend with a caregiver. They are able to demonstrate responsive caregiving activities. They carry along with them homemade play items to demonstrate to caregivers how they can engage with their children in age-appropriate play and communication. So those are things that they've done so routinely with a lot of ease. With COVID, this had to change quite a lot. And some of the things that how we had to respond, we had to work with the county government again to retrain CHVs on how to integrate COVID-19 surveillance into their routine household visits. So we did that. They were out there doing, integrating that, because with COVID, the main task of CHVs, and I think for all healthcare workers, shifted from delivery of services to COVID response. For the first few weeks or months, everyone was in the lookout, just checking who is it that has come into this village. And CHVs played a key role. So what we did was to help them integrate that into their routine household visits. So we did an assessment using HCD, human-centered design, to just assess how this had impacted their work. And so we are asking, the questions we are asking were, how has this impacted CHV's work? And secondly, how are CHVs responding? How are they coping? What strategies are they employing to deliver amidst these challenges? Our findings: clearly, COVID-19 caused a lot of disruption into the structure and the delivery of community health services. Because CHV's work, as I mentioned, mainly shifted to COVID-19 surveillance. So quality interactions between caregivers and CHVs was reduced. Contact time was reduced. Look at the context of CHV work. They visit a household. In our African setting, if you go to someone's household and you knock, they welcome you in. You're supposed to go in. But with COVID, the CHVs needed to interact with households from outside in an open environment. So first of all, they knock, they are told, please come in, and they say, no, we can't come in, you come out. That alone was not natural. And it took a lot of time for CHVs and communities to get accustomed to that. Physical greeting, very African. You go to the household and everyone is greeting you. And now you have to tell them, sorry, we can't greet. That again was a barrier to the routines that they were engaged in. You visit a household, they are small babies, a 9-month-old baby, a 1-year-old baby. What do they usually do? They leave their mother's laps and come to you as a guest. Now, in this case, you can't handle that baby. You don't know what to do. You don't know how to behave, because you want to prevent this baby from exposure to COVID-19. So CHVs then adopted new strategies to respond to this. So some of these strategies were, of course, having to sit outside as they interact with the caregivers, which posed lots of challenges. They needed to now shift, and the main focus was in helping families to put in place functional hand washing facilities. And this they did very well. So every household you visit, you would see a tippy-tap somewhere around the gate or in the compound. And so that worked really well. They encouraged families to make play items and use household equipment, household items, as opposed to them coming along with their play items. Because should they carry their play items, the children would always want to grab them. And you want to prevent that contact. So they really needed to change that again. For counseling and message giving, they moved from now demonstrating, from showing, from demonstrating closely to caregivers, to just messaging, describing, this is what you're supposed to do, and have caregivers demonstrate as they support. So really that changed. Because what we have helped train them to do is to model a behavior. If you're asking a caregiver to be responsive, when you get into that household, how do you interact with the baby that you find there? Show the caregiver that that baby can hear. So talk to the baby as well. So in this case, they couldn't do that. They were trying to do that at a distance. This really has affected the way they deliver their services. And lastly, even in the health facility waiting area, where initially they needed to conduct playbook sessions, make a number of play items for different ages of children, and have children interact with those play items, they had to change that. So in the health facility waiting areas in Siaya, known for play sessions, play box areas within the health facility, they had to change. So instead, caregivers carry with them their own play items, so they don't get assorted materials to interact with. This has really affected the way in which CHVs deliver nurturing care services. But we are glad that CHVs were able to seamlessly integrate this into their routine work. And even amidst COVID-19, CHVs devised ways to help children thrive amidst all these challenges. Thank you so much.
Thank you. Thank you, Beatriz, for that insightful conversation we've had, just reflecting on CHVs and how they play a critical role on this journey of ensuring children's welfare and thriving. Okay. Sorry, I was just being advised. A little bit of a shift. We want to conclude this session because today we're really looking at time. So just before our tea break, I want to welcome the next speaker who will be joining us virtually. And this is Professor Amina Abubakar from Institute of Human Development at Aga Khan University to share with us insights. I need to know if she is on. Oh, she's online, yeah? So, Professor, if you can hear us, feel most welcome. We're ready for you to share with us insights. Thank you.
Good morning, everyone. Can you hear me?
Yes, Prof, we can hear you.
Okay, thank you very much. I will try and share my screen. Thank you. It was really exciting to join the earlier conversation. I think I enjoyed so many bits of it. It was very enlightening to listen to the discussions on the prisons, because yesterday we had our Chief Justice. We hosted her here in opening the ECD workforce hub. So it was important to learn some of the work going on in the justice system. And I'll actually continue with the discussions around COVID-19. My topic was childcare for vulnerable children. I just want to share a little bit of what we have learned in the past few months since the COVID-19 pandemic. So I'll try to move very quickly. I know there is quite a on time. So without overemphasizing this, I think we all agree that the COVID pandemic has presented quite an unprecedented challenge for everyone globally. I think for families in urban informal settlements, there is really an opportunity that this is even more magnified, given the socioeconomic challenges they face. We at the Institute of Human Development at Aga Khan University really focus in urban informal settlements, largely because of the fact that one, there is really a high trend towards urbanization in Africa, and we anticipate that by 2050, 50% of our population will be living in urban informal settlements. Unfortunately, the infrastructure in urban informal settlement is not growing as much as the population. And we know that 50% of the people in urban informal settlements are actually children. So we have a long-term study within the urban informal settlements in Nairobi. And when the COVID pandemic hit, we had to stop the study because of all the restrictions. But we wanted to understand, what is happening in terms of the children between 0 to 5 years in these settings. And we looked at it really holistically in terms of parenting, health-seeking behavior, health service utilization, and mental health. Today, I'll give a very short snapshot of what we found and some of the key lessons. So I'll jump through that. We actually, during this time, decided that, there's a lot of emphasis on urban informal settlements in Nairobi. Therefore, we not only worked in Nairobi, but also went to Mombasa. It was a telephonic survey that involved 1,000 plus participants. And out of them, we actually went out of our way to ensure we had a percentage of families of children with disability. And we reached 165 of them. We applied very many measures in the telephonic interviews, including standardized measures such as PHQ. We took some of the questions from MISC to understand childcare, and we had very detailed in-depth interviews with caregivers and key informants. These key informants include, healthcare workers, community health workers, and daycare workers. Yeah? And here, I'll just quickly go through some of what we found. So, of course, as mentioned by our earlier speakers, what happened is because families were staying together, caregivers were spending more time with the children than before. So if you look here, it's between 82% of our caregivers say they're spending more time with their children compared to previously. And very few actually said, less than 10%, that they were spending less time. And the other thing is that most of them were spending time with their key caregivers and adults. So very few were being left at home with another child. So this, as earlier said, was good for the security of the children. And the caregivers were spending less time outside the home because of the curfews. However, for us, what's really interesting is what were people doing spending time with their children? Was there more access to nurturing care? Now, actually, I need to correct that statement because we don't have a lot of pre-pandemic data. We do have only for Kawangware, but not the others. It might not be a direct comparison, but at least this gives us a sense of how much stimulation were children experiencing while they're at home during this time. And you
Sorry,
find
Prof,
that
your slides are not changing. Can you just please make sure we're still on the first introductory slide?
Oh, I'm moving them on my side, so I'm not sure why they're not changing on your side. Just a moment. Thank you, Anil, for pointing it out. I'll just stop sharing and see what the problem is.
Yeah,
we've
got it now.
You've got it now, yeah? Okay, so which slide are we on?
Just please do presentation mode.
No, that will, I think, messes up everything. Apologies. I think we can try to just do it because I'm not sure what's happening. Is that any better, or it now just disappeared? I see a blank.
It's disappeared, but we can see the small one.
Sorry. Apologies, everyone, about that. I will need to stop sharing again. Oh, that disrupted everything because I've lost my train of thoughts. Can you see anything now? Thank you. Okay, so I will need to move to my sincere apologies about that. So I was talking about some of our key findings. We found that, for many families, children were still not receiving as much of, early stimulation, although they were at home. For instance, if you look at something like narrating stories to the children, almost 60% of parents of children without disability told us they were not narrating stories, and 53% for children with disability. We also find that for something like singing, that was a lot more, and in terms of going outside the house, but also issues like counting, drawing, or naming for children. The rates were still much lower than we would like to see. Similarly, although it's not on this slide, we find that access to digital learning was extremely low. So some families tell us, like less than 10% of the families are able to give their children any form of access to digital learning, although that was a major, target for the government in terms of continued learning. And we looked at what are some of the factors that were associated with caregivers' engagement in early learning activities for children. I'm just highlighting this because this is able to tell us who are the children who are likely to be at a higher risk of suboptimal stimulation. So children of parents who are single were at higher risk, children whose families were large, parents who had more than 3 children, and parents who are 50 years and above. So for instance, parents who are single, that might really be an indicator or a proxy of lack of psychosocial support, someone else who can care for their children when they have gone out. We found that parents who have slightly higher education, actually secondary level education and above, it increased the odds of them participating in early learning activities with their children. In terms of continued learning through play, we found that caregivers who are between 25 and 49, they had significantly higher increase in opportunities for continued learning for their children. While for parents who reported single marital status, there was actually a decrease in learning opportunities for their children. We looked, other than learning and care, we looked at healthcare, especially for children with disability. And we found for a significant number of them, actually 65%, reported that in the early days of COVID, there was a major disruption for childcare, access to healthcare for their children. And the key causes of this disruption was lack of funding, but also parents told us that, care providers or facilities were closed, their therapists were not available, medication was not there. Actually, in in-depth interviews, parents noted how much stress they experienced when they were not able to access their, daily medication for their children. We are also very keen to look at mental health for caregivers. I know we all talk about childcare, but children are cared for by adults, and they really cannot provide quality care if they're not feeling very well. And we were actually quite surprised by the burden of depressive symptoms. Between 34 to 38% for the parent children without disability and those with disability, very high percentages. And therefore it meant that at this time, many of them were feeling quite stressed and quite, disrupted in terms of their mental health. We looked at COVID anxiety. In terms of COVID anxiety, it was largely for families of children with disability. Many of them felt that, would their children be able to follow the COVID mitigation measures? They were afraid to take their children to healthcare facilities because of fear of exposure. And when you looked at mental health, what are the factors that really were driving mental health problems in this population? We found that those who are in informal employment were thrice likely to experience anxiety compared to those who are unemployed. Actually, this is a bit surprising. You would think that those who are unemployed would have more anxiety. But the way we think about it is that maybe those who are unemployed, they've already developed coping mechanism to deal with the issues around finances and economic disempowerment. But for those who had informal employment before COVID, they had a means to go out, do their work, and earn a living. And with all these mitigation measures, now that was being taken away from them. Then we found that caregivers who reported experiencing violence were twice more likely to experience mental health problems, and also caregivers who reported experiencing any form of discrimination were 4 times more likely to experience more mental health problems. An interesting and expected result was the ability to pay your utilities and repay loans being negatively associated with mental health problems. I think this might need some deep understanding on how this, has functioned to make this kind of, for those who are slightly better off in terms of their ability to provide, still reporting more anxiety. So what are the key lessons we learned in terms of, caring for vulnerable children in times of pandemic? I think with or without a pandemic, we really need to maximize the capacity of parents and adults in the household to provide early stimulation. The other thing we learned is that digital learning resources is a major hindrance for people in urban informal settlements, and I would think for many in low socioeconomic settings. And what this might have led during the pandemic is that the inequity between those of higher and lower socioeconomic status will increase, because children of higher socioeconomic status could access continued learning through various digital platforms, but those in lower settings were actually not accessing it. So this calls for us to develop more low-cost learning materials, to come up with innovative approaches where children can continue learning in terms of, in terms of this disruption. Actually, I was telling someone, our observation seems like the health sector was really disrupted, but they quickly adapted and found ways to bring up children back to the health setting. But the education sector took a little bit longer and therefore quite a lot of time was wasted. Now, clearly economic empowerment, yeah, that we can all agree for vulnerable families, but also comprehensive mental health services for caregivers, not just dealing with mental health issues, but looking at ways in which we can really look at the root causes, violence, discrimination, economic disempowerment for the women, because most of our participants were women. But I think from our study, one very interesting thing that came up is the need to develop a simple risk indicators. So for instance, we work with community health workers a lot. We're investing in supporting, families. But should this, is there a need to be able to say, who are the people who are most vulnerable in terms of disruptions? In terms of humanitarian times, who should we spend more services to? So for instance, in all our indicators, single mothers had a much more difficult time coping with the pandemic, and therefore they needed more support at that time. I can imagine maybe because of the, restriction in movements, maybe their psychosocial, their social support systems were disrupted. But what also came out clearly is promotive and preventive factors for child well-being came in handy during this time. For instance, higher maternal education was very protective for children and ensured continued care and support for these children. So it just means we need to always continue investing in promotive and preventive services, as opposed to waiting for, to always be intervening to reduce risk or to, to deal with negative impact. Thank you very much. And apologies for the earlier technological hitch.
The one thing that I would like to request us to do as we go for the tea break, we will come back and take some of these questions later on in a plenary. You will notice that we have skipped presentations because we've been requested by those that were to present to avoid having them come on because they had made this in other sessions. And that's the IDELA approach and also the end-line survey on Let's Play, etc., and spaces for kids to be kids. So what we want to do, all of us, as we walk out through this door, we are going to stand on the stairs there and be able to take a photo, which will be an MOV for us, but also that which we will use for the next conference. Therefore, what we are going to do is we will stand out there, take the photo, and then we will break out, go into our breakout sessions. Remember I said that we have 3 breakout sessions that we need to run for 1 hour max. And that will be actually 45 minutes, not 1 hour. These concurrent sessions will be one in this room, chaired by Dr. Anil Hamis, whom you heard speaking while Dr. was making Professor was making a presentation. This is Rethinking Childcare Workforce and SDGs and Emerging Issues. We will have it in this room, and that will begin at exactly 11 o'clock. Then we will have breakout room number 2, which will be Dr. Benson Odongo led, and it is going to be happening in the room on the other side, the implication for practice and policy. Then breakout room number 3, where Immaculate Salaon will be chairing, will be the one on AFCAN and its catalog of abstracts on for the ECD network conference. So we are requesting that we go out, 5 minutes will be spent taking this photo, the 15 minutes thereafter taking tea out there, and then we walk to our breakout room sessions and be back here at 11:45 to be able to get into the plenary session. Thank you for the morning session. We will recognize the guests that are here with us. We have several CECs and directors present. we will recognize you in the session that is coming after this, and we appreciate your presence with us this morning. Asante sana. Let's all just stand for the group photo out there, and then we can go for our tea break. And in the same vein, please make sure you also visit the exhibition booths just to see what is in there.
This is a book.
Hiya. Watoto. Everyone wants still to do better. Ufaulu mama wape kukwea. We want the next generation tuweza. Tukizeeka tuwe na watu wa kutegemea. Everyone wants a child to do better. Ufaulu mama wape kukwea. We want the next generation tuweza. Tukizeeka tuwe na watu wa kutegemea. I've learned the secret of raising great kids. Single more rahisi kama vile ABC. Strong foundation gives a great finish. Kwa watoto ni kutoka umri wa 0 to 5. I've learned the secret of raising great kids. Single more rahisi kama vile ABC. Strong foundation gives a great finish. Kwa watoto ni kutoka umri wa 0 to 5. Love, song, play and stories. Buja buja baby baby. Wahusishe kila jambo. Love, song, play and stories. Buja buja baby baby. Wahusishe kila jambo. What you do? Love, 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 love the baby. Sing, sing, sing for the baby. Play, play, play with the baby. What you do? Love, 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 love the baby. Sing, sing, sing for the baby. Play, play, play with the baby. Buja buja baby baby. Engage them hata wakiwa tumboni mwa mama. Zungumzie. Activate their brains with song and stories. Engage them hata wakiwa tumboni mwa mama. Zungumzie. Activate their brains with song and stories. Wakati unapika mweleze, unapoenda shamba mpeleke, akiuliza swali mjibu. Buja buja baby baby. Wakati unamwosha mwimbie, unapoketi umchezeshe, ubongo wake ufunguke. Buja buja baby baby. Love, song, play and stories. Buja buja baby baby. Wahusishe kila jambo. Love, song, play and stories. Buja buja baby baby. Wahusishe kila jambo. What you do? Love, 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 love the baby. Sing, sing, sing for the baby. Play, play, play with the baby. What you do? Love, 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 love the baby. Sing, sing, sing for the baby. Play, play, play with the baby. Buja buja baby baby.
Mama baba dana waya owadwa Mama baba dana waya owadwa Ajiduto nyalo ponya dongo. Ajiduto nyalo ponya dongo. En gima yoti munyalo timo. En gima yoti munyalo timo. Ajiduto nyalo ponya dongo. Mama baba dana waya wadua Mama baba dana waya wadua Ajiduto jiduto nyalo ponya dongo Ajiduto jiduto nyalo ponya dongo Enigi mayoti munyalo timo Enigi mayoti munyalo timo Ajiduto jiduto nyalo ponya dongo Ajiduto jiduto nyalo ponya dongo Nyathi en mwandu Nyathi en mwandu Ajiduto jiduto nyalo ponya dongo Ajiduto jiduto nyalo ponya dongo Kuchako kabodati Tabro dongo maber Irit maber Kendo kategno
Public photos without mask.
All right, thank you very much. This is the ECD, the fourth ECD National Conference that is happening right here at the Jaramogi Oginga Odinga University of Science and Technology. And as you can see, is already on, and the first session is already done, and the session that you're seeing currently is the photo session. Now we want to hear some of the things from the participants and on how the first session was like. We had presentations from the various individuals, and I'll be very happy to hear from views from the delegates, what they feel about the first session. Tell us your name and how's your feeling about the first session.
My name is Leonard Chumo. I come from Mutabiti, Africa, and the outgoing chair of the Kenya ECD Network Board.
Yeah, wow. So how do you feel about the session that just ended, and what is your expectation for the next sessions?
It's great. There's a lot of learning, especially the recent learnings from COVID-19 situation and how that affects young children, teenage pregnancies, and how we can rally our support, social networks and system to be able to provide early quality care for young children. So I think that's a lot of knowledge at the national level that we can continue to improve on, exchange, especially as a country, from government, civil society practitioners, universities, researchers, and so on. And that raises the platform for discussing issues of young children at a good level. And I'm impressed. The participants, the networks that are being developed here, forward thinking in terms of what we can do together as a country. I think this is a good conference for children.
All right, thank you very much. So from here, where are you going?
We are now breaking out for breakout sessions. We have 3 concurrent sessions to, go down to earth and discuss some of the issues around childcare, policy, and other issues.
All right.
Yeah.
All right, thank you very much, sir.
Thank you very much.
All right, I'll be glad to hear from another person on what they feel about this session. Let me get someone else. Hello, sir.
Yes.
What's your name?
I'm David.
Yes.
Yes.
Just tell us what's your feeling about the session that just ended?
Oh yeah, the session on COVID which just ended.
Yes.
It is very beneficial to the community at large and also to the ECD children, because we are having the stakeholders with us here, whom I'm very sure they'll be able to transmit this knowledge back to the institutions as they go back home.
And maybe what is your expectations after this session for the next session?
My expectation for the next session, though we are going for a plenary discussion, I expect that we come up with some conclusive issues that can finally conclude the workshop we are holding at this time.
All right, and maybe what organization do you represent, and what's your name, sir?
Oh yes,
Good to mention that.
I'm David Wawero, representing Murang'a County as an assistant director in education.
Wow.
Yeah.
So, sir, Murang'a County, what do you think you're going to learn from this session, this conference, and maybe probably implement in Murang'a County?
It is really an insight and a good mental uplift, whereby we'll brainstorm on whatever we will be doing and be able to jab it up, so that our children are able to benefit when we go back to the institution.
All right, thank you, sir.
Thank you.
Thank you very much. So yes, thank you very much, and I'll be glad to hear from someone else. Yes, kindly, if you can offer me a minute of your time. What's your name?
My name is Isabella Uwar.
Yes.
I'm working with KMET, that is based in Kisumu, but we're also implementing nurturing care in Siaya County.
Yes. So, what has stood out for you in this session?
What has really stood out for me is the presentations were nice, and then they were also being very contextual in terms of highlighting nurturing care implementation during COVID.
Do you mind coming, stepping a bit? We move closer to the camera as we speak. The camera is there, yes.
So what has really stood out for me is the key highlights on nurturing care implementations during COVID, and what are some of the implementations that have been done in regard to COVID-19, and some of the strategies that were laid out really brought out a well thought out process in terms of curbing the pandemic and ensuring that the children were really taken care of during this particular process. And also the representation by the county government officials in these particular functions really brings out the support that we really needed for this intervention, because what we want to really strengthen is the county-led approach, where we really want the county to take the lead in this process, and also even to go to the budgeting part of it so that we sustain this particular initiative. Yes.
So maybe, do you have a specific presentation or anything that you feel like, this one hit me really hard and maybe I need to make a change around that?
One presentation that really hit me hard was the part of the prisoners with their children. It's something that has been really not a neglected area, that some of us need really to work around and ensure that every child is not left behind. Even those that are in prison should also be taken into consideration, and the caregivers given much information in terms of taking care of their children.
Right.
So that really stood out for me.
So, all right. Thank you very much. Maybe let me look for another person to give us their views. It's an interesting thing, and we've heard from the delegates mentioning issues to do with the prisoners, which was an amazing presentation from the prisons commissioner. And we have a lot of things that we are learning from this conference, and I'm sure if these strategies, these discussions are implemented fully, then we are going to have one of the most amazing country, a child-friendly country, and a country where children are really valued, and the needs of children and the voices of children are really taken care of. So let me get another views from another delegate who has been part of this conversation. Just tell us what's your name, and tell us about today's morning presentation or session. What do you think about it?
So my name is Dr. Caroline Monge from the Ministry of Health, and I had the opportunity to present on the effect of COVID-19 pandemic on the health of children in Kenya. Yes. So Caroline, you presented, and maybe what are some of the key findings from your presentation that you feel, should be really be considered hard and taken very serious consideration? So we did see initially a decline in attendance of children. They became less sick, I'd want to believe. There were less numbers seen at outpatient facilities. Initially, there was a closure of non-essential services at health facility level, but the health sector quickly re-strategized and made these services accessible. So the important thing is to plan and be ready for an eventuality such as a pandemic, so that we're able to program services and not affect delivery of services to both babies and children.
And maybe what do you think now the solution to these problems? Do you have any recommendations that you came up with?
Yes, we did give guidance. We have guidelines on the management of COVID-19 in children, the pediatric population, and we also have various structures of coordination. We need to work together as multi-sectoral coordination teams to ensure that we are delivering services to our children when they need them, both at facility level and at household or community level.
And we understand we are talking about the health of children and COVID-19, and as a country there's already no vaccine for children, for example in Kenya. did you try to look at maybe how COVID-19 would be affecting children in terms of their health, and maybe the time that COVID-19 vaccine will take, maybe what impact it will have on children?
Yes, so even in countries that are more developed than us, they are yet to start vaccinating children. Studies have been ongoing, and some are indeed about to start vaccinating children. For Kenya, as I presented, there were cases of COVID-19, but the mortalities as compared to the adult population have been quite low. So we do know it's not a major disease burden for our children. However, if we have vaccinated, if the country will indeed program for future vaccination of children, when resources allow and when guidance from, we rely on guidance from our international organizations that also look at safety and efficacy of the vaccines in children. So it is a future plan for us as a country to include children in our vaccination schedule for COVID-19.
All right, thank you very much for that elaborate explanation. Now, we are going, after this, we are going for the breakaway sessions where we are going to have more presentations coming from the delegates who are represented here. And we have a very amazing presentations. You've heard about issues to do with prisoners, children, how children are affected, maybe when a parent is taken to, the parent is taken to prison, and how it affects children and all that. And as we wait for more people to get their views, I'll take you back to studio as we prepare to go to the breakaway sessions in the various rooms that we have. From the ground, my name is Colin Sorono. We are coming to you live from Siaya County, Jaramogi Oginga Odinga University of Science and Technology, and this is the 4th ECD conference happening here in Siaya County.
Rwala is a community organization, so it started by the community themselves, organizing themselves, so that they could start an hospital that could help their community members, because people were walking long distances before they could get services.
Globally, we have over 250 million children who fail to reach their age-appropriate milestones.
According to UNICEF, over 200 million children globally fail to reach their developmental potential in the first 5 years of life due to poverty, nutrition deficiencies, poor health, and psychosocial services.
Nurturing care opuonjowa ni mondo mi wariure e tich kanyakla mondo mi dongo mar nyathi obed makare.
We have nurturing care framework incorporated in the community health strategy, so it becomes easy to then incorporate this as a package that community health workers are delivering on top of what they have been delivering on a day-to-day basis. So last year there was the launch of the new community health strategy and also policy. So inside there is nurturing care as some of the services delivered at household level by community health workers. So that gives us a very good opportunity to then now scale up the work with community health workers in delivering nurturing care at the household level.
World Bank records that many countries invest more in children when they are older, yet research shows that the returns on investment are more substantial in children during their earlier years.
ECD has strengthened maternal and child health.
The nurturing care components, there are 5. Okay, we have good health, we have adequate nutrition, we also have nurturing and care. 4th one is we have safety and security, and then finally we have opportunity for early learning, where we measure on play. Yeah, we always encourage them to let the children play, because Play developed so many things in nurturing.
Through its community-led health model, Lola Community Alliance aims to build the capacity of rural communities to advance their own comprehensive well-being. It is within this model that Lola implements a robust ECD program based on WHO's Nurturing Care Framework.
The ECD program, when it started, I've gone to training twice. We have the first one was the introduction into the ECD. Then we had another one on toy making.
In the last year, Lola incorporated nurturing care components and care for child development into its community health services to further improve health outcomes for young children.
I've been taught on the maternal and child health, the ECD one, the sexual reproductive health, and even the COVID-19 as a respondent CHW. And this one has also helped us because whenever I have the knowledge, I disseminate to the community members. This one has helped a great deal and our lives have improved.
Each month, community health workers conduct integrated parenting sessions where caregivers of children between the ages of 0 to 4 years receive parenting education to enhance their skills. Healthcare workers based in Luala and its partner facilities, on the other hand, engage ANC clients on early stimulation sessions on play and communication for caregivers.
For Migori County, we started 2016. That is when the national government trained the national trainers. I was one of them, trained as a national trainer in 2016. In 2017, we did another 2. So as a county, we have 3 trainers as national trainers for care for child development. We realized that number was not enough, but we continued introducing it because it is also incorporated in the government mother-child booklets. So through that, we've been having orientation of healthcare workers, but the real scale-up has come to us last year, but one through the support of Luala Community Alliance, where they are really, especially, we are having now Rongo sub-county, which is one of the sub-counties, as a pilot sub-county, because in all the 11 GOK facilities, the 9 plus 2 private, have healthcare workers trained.
According to Kay's Foundation, ECD interventions should focus on both long-term and immediate changes in the lives of children. Luala's ECD program integrates immediate services like immunization, NHIF, and birth registration with caregiver education and the importance of early stimulation and responsive parenting. Children also get to play using toys created from locally available materials. These initiatives go a long way in preparing children for better outcomes in life.
The Nurturing Care for ECD program is actually, we are the implementer for the Eastern African region, from Zambia to Ethiopia, Tanzania to Mozambique. We are actually the ones who are implementing it. This program was actually, it was launched back in Harvard, where His Excellency the Governor himself went there, made a visit with the team from the county, and actually this baton of the nurturing care was handed over to him, and then he promised to come back to Siaya County and implement it for also all the neighboring counties. So we are actually the county modeling it for Siaya, and for Kenya as a whole, and for the whole of the Eastern African region. Initially, back in 2014, according to the Kenya Demographic Health Survey, it was found that there was high level of malnutrition. Issues like malnutrition, we call it stunting growth, low birth weight were very prominent because of probably issues to do with nutrition, poor visits to the health medical attention, and then poor we call it responsive caregiving, it was not up to date. So when now the nurturing care program came with the 5 elements, that is good health care, good nutrition, security and safety, responsive caregiving, and opportunity for early learning. Now we are seeing that from the campaign that we have been doing, the parental engagement, the so many workshops, and then the which we have been doing in a multi-sectoral nature, whereby we involve every sector, from the devolved to non-devolved. We are moving together as a unit in ensuring that this program is implemented.
Siaya County has about 1,000 ECD centers. Now our ECD centers are vast across the county. We have both private ECD centers and we have public ECD centers. Of the 1,041 ECD centers, we have 684 ECD centers that are public. When we come to ECD, we don't look at the education itself, because at this point I am talking about early childhood development in terms of learning, which is the 4-year-old to the 6-year-old. However, when we look at ECD, we look at it as holistic as it can be. A child's development starts from conception to 8 years old. This is the place where the brain of the child develops, and the way the brain will develop will affect the way the child is going to grow up in the future. Now, your child should be looked at in those eyes, because your child is your future. How do you take care of your future? You protect it. So those are the strategies that have been laid out under Nyathi and Mwandu, so that this child will be brought up in a holistic kind of way. Nyathi and Mwandu is the rallying call. It's in Doluo. That means a child is wealth. If you give that child a good foundation, that child is wealth. And so, being the patron of Smart Start Siaya, I've been a patron for 2 years, following realization and the introduction from the county executives who went to Harvard University for a program on early childhood development. And from Harvard University, when they came back, they realized that early childhood development is very critical in development. And if we invest more on early childhood, then the return on investment is very high. And so we realize that mostly, even us as parents, governments, we don't really take much interest when our children are young. And so we lose a lot, because that is the time a child develops very fast, the brain of the child develops very fast.
This project of SCORE ECD is looking at a child at 1,000 days. 1,000 days means from conception to 2 years. And we look at many things around these 1,000 days. We are looking at the health of the mother during pregnancy and after pregnancy, and then during the 2 years, how is the mother? Then we are also journeying the child and assessing the milestones of the child. The milestone of the child, we are looking at so many things, health-wise, nutrition, education, the formation of the brain, how does the child react to the environment. Along that, we are also looking at the immunization of the child. How is the child's health going to be taken care of within the 2 years? The child has to go through all the immunization, and this helps the child to remain healthy.
Male partners, we really train them to say that a mother cannot raise a child alone. They have to be two. So there's that responsibility of a father in the house. So fathers, we see them coming to the clinic. They bring their wives to the clinic, their children to the clinic. Whether the mother is pregnant or not pregnant, they come with the mother in the clinic. So it's a habit that they have really developed, and they are coming frequently for that, and they feel it's just too good for them. If a father is not able to escort the mother to the clinic, a father will provide transport. And the father also is taking a responsibility of reminding the mother, your time has reached. Did you go to the clinic? And then when it comes to nutrition also we try detailing them and also training them to provide. That is by initiating the kitchen garden around them.
Uzuri nilikuwa nafundishwa hizi vitu na naenda kuambia babake. At first alikuwa anaona ni ngumu. Sa the more niliendelea kumwambia ndiye akaanza kupractice. Na the difference is there. I've learned things that all things is not about money. How can I find a balanced diet? They introduce us to kitchen garden. So the kitchen garden unaeka sukuma wiki, spinach, even kunde, such things. So the little money you have, even if it is 50 shillings, you can go and buy your mena. Then you take sukuma from the shamba. Then you cook with ugali. So the child has balanced diet. Kuna ugali, which is carbohydrates. Kuna sukuma, which is the vitamins. Na kuna omena, which is the protein.
I have learned that upbringing of a child should not be left to a woman alone. For you to have your children growing the right way on the positive direction, the child that gets everything that you need in life, you, the man and the wife, must work together. Now, as a man, what should I do? I should provide to the children. I should help my wife to perform the domestic chores like cleaning the child should not be left with the woman alone. I also play with my children when I'm around. Play is something very important in that we learn that when you play with the child tends to know you better. The child psychomotor system of it can grow. The child comes out when he or she is a very strong person. Intellectual development can also be realized when you play with your child. And during play, we don't need to go to the shop to buy the play materials. We make them with the local available materials. We improvise. We find that it is very expensive, and the money that we will use to buy some other things that we use in the house, we waste them in buying these items. Why don't we use the local available materials to make dolls like this? We have made so many of them, and while you are making, you find that the child also enjoys following what you are doing.
We have so many materials that you can see we have hung others around. We have a play box, which we make rockery that we provide every morning. Once a child gets in, he is free to pick. We ask the mother to pick the toys and try to engage with CHVs again to play with them around. We train them that we are supposed also to make toys to our young ones at home, and this chart, there is some days we had so many charts that we were able even to give to the communities, household communities, that they can also to monitor those ECD activities at the household. ECD activities which are being promoted by that organization, that is BATH, it has encouraged many mothers to come to our facility because they guide us what we are supposed to do. They have taken us to courses, some trainings, and their routine. They come to this facility routinely to check how ECD activities are being going on. These activities of ECD starts from the community. They have also trained our CHVs on ECD activities. They can also able to refer to us, the hospital, also in CH department, whereby we examine the child according to developmental milestone. Then we refer accordingly if the child has not achieved according to the age.
Sasa wakina mama huwa tunawatembelea, ni wewe mwenyewe ujipange. Kama mimi mwenyewe najipanga at least in a month, mama namtembelea mara 2 mara 3. Sasa vile ninaenda na book appointment, manake wajua wako na kazi wanafanya. Hiyo tarehe ambayo amekuja na prepare topic ambayo tunaenda kuongea naye. Tuko na 17 topics ambazo tunacover. Kuna introduction to child caregiving, kuna secure attachment, kuna child development, kuna the importance of play, appropriate play for children and caregivers, inclusive caregiving, making toys from local materials, kuna under communication, kuna the importance of communication, play and responsive caregiving. Under health, kuna safe pregnancy and delivery, kuna basic newborn and young child health, kuna malaria awareness, HIV and AIDS awareness. Under nutrition, tunaongea about breastfeeding and complementary feeding, balanced diet. Under protection, tunaongea about safe home environment and wash. Alafu topic ya mwisho ni positive discipline.
Things like malnutrition has gone down, stunting has gone down, child mortality rate has gone down, the issues like mobility and the rest have gone down. Right now, a number of mothers are now delivering in health centers. Before this program came, actually a number of them were being catered for by their midwives, which was actually leading to a lot of child deaths.
Nikiwa pregnant, nilikuwa nafunzwa jinsi ya kuongea na mtoto. Unashika tumbo lako, unasikia penye akilalia huku, yani utasikia mtoto akicheza, mtoto saa zile kwa tumbo anajua sauti ya baba. Mama